Okay, so welcome everybody to the new year and the Center for Medicinal Cannabis Research. We call it the Investigators Meeting. These are monthly meetings where we get updates from national and international scientists. You can get CME credits for this meeting. You do need to ultimately register with the CME group, and then you can simply text the code and you will get credit. We're also recording this meeting as well. So today we're very pleased to have Dr. Daniele Piomelli present. I think Dr. Grant, you'd like to say a few words, and then I'll give a more formal introduction.
Hey, Daniele, welcome back to our session. I hope you can hear me all right. I am stuck in a jury selection room, so I can't wax eloquent about welcoming you, and we'll ask Tom to do that on my behalf. But we are all very delighted to welcome you back and to hear about this work.
Thank you so much, Igor. Good luck. Tell them you're a scientist. They'll exclude you right away.
Yeah, there you go.
Well, I hope they'll exclude me on mental health grounds or something.
Okay. Sorry, I'm very pleased to welcome Dr. Piomelli. Dr. Piomelli began his career studying with two future Nobel laureates, Drs. Eric Kandel and Paul Greengard, and then subsequently worked with a third Nobel laureate, Dr. Gerald Edelman. He ultimately joined the University of California, Irvine, where he is now Louise Turner Arnold Chair in Neurosciences and Distinguished Professor of Anatomy and Neurobiology, Pharmacology, and Biological Chemistry. He's the author of more than 470 peer-reviewed articles in prestigious journals, 3 full-length books, and more than 38 patents. Since 2016, Daniele has served as editor-in-chief of Cannabis and Cannabinoid Research, one of the premier peer-reviewed journals entirely dedicated to the study of cannabis, its derivatives, and their endogenous counterparts in the human body. He directs the NIDA Center of Excellence, or ICAL, for impact of cannabinoids across the lifespan, and UCI's Center for the Study of Cannabis. Daniele has been a valued collaborator with many cannabis scientists over the years, is a good friend of the CMCR, where he also serves on our National Advisory Council. Today, Dr. Piomelli will be discussing his work on cannabinoids for the treatment of pain, the case of sickle cell anemia. As Igor said, Daniele, thank you very much for doing this today. We appreciate your presentation.
Thank you so much for having me, Tom. It's always wonderful to be with all these friends. I assume you can hear me, right? I don't see
We are good, yes.
faces. So I'm going to go ahead and share my screen. And bear with me for 1 second. There we go. All right. So I'm really, really happy to talk to you today about this topic. I'm sure most of you, if not all of you, are intimately familiar with cannabinoids in the treatment of pain. And I will be presenting data from a preclinical study that we conducted with support from the CMCR. And part of it was published and part of it will be soon published. But I am especially happy because the question that the broad question that we are addressing today, and we have been addressing for quite a while, I finally start to see some light at the end of the tunnel. The question, of course, is cannabis a safe and effective analgesic? And this question dates back really over a century. And what I'm showing you is the cover page of a commentary on the American and British Pharmacopoeia published in 1848. And in this commentary, cannabis was first introduced as a drug in to the American pharmacists and physicians, as well as to the British pharmacists and physicians. And with these words, the author of this commentary wrote that on trying Dr. Robertson's extracts, which is a type of extract that was used, of cannabis extract that were used at the time, once for toothache, I found, says in the author of this commentary, that about 4 grains taken at 3 a.m. caused in an hour cessation of pain, It plays a numbness in the limbs, giddiness, and a rapid succession of unassociated ideas, an impossibility to follow a train of thoughts, frequent intervals in sleep, and slight increase in the force of the pulse. So there we go. We have highlighted in red what we all would like to see, cessation of pain in so many people who suffer from it. But also we see highlighted in black what we really don't want to see unless we're pursuing the quote-unquote recreational aspect of cannabis. So this question has been haunting people for a while, both preclinical and clinical researchers. And the number of preclinical studies looking at cannabinoids in pain is staggering. There are probably over 1,000 studies, and they were not so long ago reviewed by David Finn and Andrew Rice and collaborators for the American Association for the Study of Pain. And the conclusions of this review was that there was substantial evidence from animal models, I'm reading, supporting the contention that cannabinoids and endocannabinoid system modulators hold promise for analgesic drug development. And the authors concluded, although the challenge of translating this knowledge into clinically useful medicines is not to be underestimated. And I don't think anyone in this audience underestimates that challenge, because we all know that studies have been quite a few, but all very small, most of them with positive results, some with negative results. But the end, conclusions have always been made hard because of the size of those studies. Let me give you some examples. I think the earliest one that I found was published by a good friend of CMCR, Dr. Donald Abrams, and myself, Dr. Donald Abrams. And this is a published study of almost 20 years ago, was the use of cannabis in painful HIV-associated neuropathies. And in this study, which I'm sure, again, many, if not all of you have seen and probably remember, this one graph stands out as being particularly relevant, where you see these symbols here. The close symbols indicate patients that were treated. They were smoking, as you can see, cigarettes containing a fairly low concentration of THC, I think 3.5%. And these patients had an improvement in their pain scores, whereas those smoking a placebo cigarette had no such improvement. This one study was, in a way, the phase that launched 1,000 ships. There were quite a few studies that followed up. But again, as I said before, for a variety of reasons, all these studies were fairly small. And the results, even when they were positive, were always viewed with a great deal of skepticism. In addition to these clinical trials, experimental human studies have been done by various investigators, and the group of Margaret McHaney, and now with Ziva, when Ziva Cooper was her postdoc, and now Ziva herself at UCLA, have been very active in this area. For example, this one study published in 2016, again, almost 10 years ago, applied a very common experimental approach protocol to study pain. Is the cold pressure test on human volunteers in a laboratory setting, where basically the subject puts a hand in cold water, and the investigators measure the time it takes for the subject to pull the hand out of the water. And this was a relatively, again, small study that included both men and women. And the active cannabis was the standard NADA cannabis, so 3.5 to 6% THC. The results, I'm going to move this. I don't know if you can see your own faces here, but I can see the data. The results here were very, very interesting. To begin with, there was, in effect, a clear effect on latency to report pain and the latency to withdraw hand, which indicate pain sensitivity and pain tolerance. And so this effect was clear, and especially for pain sensitivity. But it was also sex dependent, where men were more sensitive than women. Small study, experimental setting, but still going in the right direction. So, So when the National Academy of Science Committee they reviewed the health effects of cannabis and cannabinoids in 2017, looked at the data that was available until then, what they concluded was the following, and it's conclusion 401 in the book that you see cited here, the first page you see, cover page you see here. The conclusion was there is substantial evidence that cannabis is an effective treatment for chronic pain in adults. Now, substantial, I emphasized the word substantial because technically it's not the same as conclusive. Conclusive evidence is what the word indicates. Substantial is short of being conclusive. And the separation from substantial to conclusive, which when we wrote this report at the end of 2016, at least I optimistically thought was going to be arrived at in about 2 to 3 years, maybe 5 years. 10 years later, still, almost 10 years later, still is not available, at least not until we will see in a minute, last December. So the question then arises that how we address the nature of the link between cannabis and analgesia. Is cannabis safe and effective as an analgesic? And there are two ways of doing this. One, of course, is with appropriately powered placebo-controlled RCTs, randomized controlled trials of chronic pain in adults. The other one is with preclinical studies and N=1 human trials that can aid in the selection of one or more suitable chronic pain conditions. And I know we are all sophisticated here, so we know that pain is a construct, is a very heterogeneous construct with multiple facets and multiple endophenotype, if you wish, if I could use that term. So this is really where I would normally stop, and I would say, okay, we still don't have anything conclusive. But some of you probably have seen this paper. It just came out in December in Nature Medicine from a very established German investigator who has worked on THC and cannabis for many years, Matthias Karst. And his name is associated also with prior studies that are very thoughtful and well designed. But in this study, and so I'm going to have to move your little faces again because I can't see. In this study, let me just give a brief description of that. So this was a multi-center, double-blind, randomized, placebo-controlled trial of 820 adults with chronic low back pain, in which 394 participants received the active compound, the verum, the active compound, and 426 received a placebo. It consisted of 3 treatment phases. There was a 12-week double-blind placebo-controlled treatment for primary efficacy evaluation. A second phase was a 6-month open-label extension, and a third phase, phase C, was a 6-month continuation with randomized withdrawal. So this was a general trial. The dosing is important and interesting because, as every pharmacologist knows, there is no such a thing as a drug. There is a dose of a drug. And in this particular case with cannabis, we all know that there are a lot of heterogeneities there. And so the authors were very, very careful in defining their dose units and what went into the dose units using a variety of analytical approaches. But they basically show that they set this dose unit THC at 2.5 milligram, which is a fairly low dose. This is not a dose that would produce a high certainly not a high in an experienced individual, and probably would just make give a little bit of a buzz to I want to say an 80 kilogram man, maybe a little bit more in a 60 to 70 kilogram woman, but it's a very low dose. Then along with THC, we have 0.1 milligram of CBG, which may or may not be relevant, but it's important to point out, and 0.02 milligram of CBD, cannabidiol, which probably is not relevant, but we cannot exclude that at this stage of knowledge. The dosing regimen was starting with a 1-dose unit each evening. It's important at night for reasons of preventing potential side effects, going around balanced or high, which by the way didn't happen. And patients were titrated upward. So the maximum single dose was 8-dose units, about 20 milligrams, and the maximal daily dose was capped at 13-dose units, about 32.5 milligrams of THC, which starts to be a significant dose. On average, the dose reached during the study was about 7.6 dose units per day, about 19 milligrams of THC on average. So I am not a clinical trialist, so you will forgive me if I don't do justice to this work. But I was quite impressed by the data as I saw them in the Nature Medicine paper. This is one set of data I'd like to share with you. The gray line is the placebo, and the blue line is the verum, the THC, CBG, CBD mixture. And you can see here that the trial lasted 4 weeks, and then there was a stoppage, and then there was a washout, and the effects emerged by week 2 and remained significant in week 3 and week 4. And to me, and this is me, everybody has different opinions, but secondary endpoints are really important because of what I believe pain is. And so to me, it was very interesting to see, for example, that the cumulative dose of ibuprofen was reduced significantly, that the quality of sleep was improved. And so most, or at least many secondary endpoints reached statistical significance. So this, again, this is not our work, and I always follow Dr. Karst's work, and I admire his work, but I'm not a clinical trialist. So there might be colleagues here online who may have different opinions. I'd be happy to hear them. But what I took from this study is some hope. The hope that we finally had one conclusive study with a sufficiently powered and well-designed, and with a knowledge of what was given. By the way, the THC was given orally. So the knowledge of what was given was sufficiently determined that we could draw conclusions, as opposed to, smoke some pot or whatever, which we have heard for so many years. So obviously additional studies are needed. But I feel that for low back pain, I hear that there is a study designed here by the CMCR. It would be lovely to see the data when they become available. But also other pain conditions should be taken into consideration. And this is where my own work as a preclinical scientist comes in, because I feel that preclinical studies can aid in the selection of conditions in which THC may or may not be applied. Again, I want to stress this, what I think is an important point. Pain is, we call it with one name, and we all think we know what it is, but the reality is that we don't, and we shouldn't be calling it with one name. Unfortunately, we don't have another name. We don't have multiple names defining multiple conditions, because we don't have that level of phenomenology yet. But we can get a general sense, and that's where I think preclinical studies can be useful, selecting pain conditions in the human eventually THC or cannabis could be applied. So sickle cell disease is one such condition. So SCD is a genetic disorder, and when I first learned about it, when I first studied it, it's a disease very common in the area of the world I come from. And I never really paid too much attention to the fact that its main phenotype is actually excruciating pain. It is a hemoglobinopathy, and is caused by a single point mutation in the beta globin gene, which produces a mutant form of hemoglobin called HbS, hemoglobin S. After sickle. And the reason why it's called sickle is because when the subject who carries this mutation and it has to be homozygous, goes in under low oxygen conditions, the red blood cells become deformed into sickles that are very rigid, and they obstruct vessels, especially in the microvasculature, causing local ischemia, inflammation, and tissue injury. And the tissue injury, and these are called, by the way, vaso-occlusive events, and the tissue injuries inevitably cause a very profound pain. And pain ranging in phenomenology, again, from recurrent acute crisis to persistent chronic pain with neuropathic features. And they may have the same etiology or maybe have slightly different etiologies or different etiologies. We don't know. But there is clearly here too a heterogeneity of pain forms. But SCD is now treated in a variety of different ways, not very well, but there are some drugs that improve the basic phenotype, but not the pain. And pain remains not just as an episodic complication that we can fix, but as a disease dimension that we actually have to deal with. So again, our good friend Donald Abrams, working with Kalpana Gupta here at UCI, tackled this issue with a clinical trial that was published a few years ago. This was a trial of vaporized cannabis. This is the NIDA cannabis, 4% THC. I'm sorry, this is not NIDA cannabis. This is the Jazz Pharmaceutical now cannabis. And 23 participants in 5 days. And, the data are basically here. There is really no difference between cannabis and placebo. But two things are important. First, it's very, very small trial. This is 10 times less, 40 times less than the Karst trial, and it only lasted 5 days. And also, the composition was different in terms of THC and CBD. We have a lot more CBD here, almost 5%, than in the Karst trial. So, but that study was, I think, intriguing enough for us to write a proposal to the CMCR and say, look, there is something here. Why don't we take a closer look? And the CMCR was supportive of this. I'm very grateful for that. And so with my former postdoc, Alex Mabutani, former because he's now a faculty at the University of Texas in Amarillo, we started a study in humanized mouse, in a humanized mouse model of SCD. These are mice that express HBS, but and we can use as controls mice that express a normal form HBA. So they're both controls and mutant are humanized, and which represents a fairly decent control. So we have done two sets of experiments. One was published in 2024 in a study that you can see here, and I will briefly go over those published data. And another one is a study that will be hopefully published soon. So let me go over this. So this is, again, these are mice expressing HBS or expressing HBA, where they're called HBAA or HBSS because they're homozygotes. So we carry the HBAA as a control of the HBSS. So if you now look for a second at HBSS, and the number that I'm pointing to is the dose of THC that we're giving to these animals, we are looking at two different parameters, one on the left and the other one on the right. On the left, we are looking at withdrawal latency, which is a measure of hypersensitivity, basically called hyperalgesia, if you wish. And to the right, we're going to be looking at mechanical allodynia. So you see that increasing doses of THC, this is delivered by IP injection, cause a dose-dependent reduction in the gap in latency. So the latency was normalized, and was normalized already at 1 milligram per kilogram THC. which again is not a very strong dose, and I will show you some data in support of that. Now, this very same dose given to HBSS animals, so these are the sickle cell animals. If we give it to the control, the humanized control, you can see that there is no effect. So this is not a quote-unquote analgesic effect proper, is not an effect on basal nociception, but is an effect on the hyperalgesia caused by the disease. And for those of you who like curves, as I do, this is the very nice sigmoidal curve with the percent of maximal possible effect showing an ED50 of about 0.45 milligram per kilogram for THC. And now if we move to mechanical allodynia, the result is essentially specular. There's no difference there. And ED50 is exactly the same, 0.43 milligram per kilogram. So acute THC, this is a single administration, does attenuate pain in this animal model in a dose-dependent manner. If you look at time course now after a single administration, what we see here is what follows. So these are 0 hours after administration, 2, 4. So these are 0 hours before administration, 2, 4, and 24. So because we're looking at mechanical allodynia here, but we have similar results in cold hyperalgesia, you have to consider that when the graphs go up, it means that the pain is less. And indeed, here, 1 in 3, we can see within 2 hours a very clear effect, basically a normalization, and which persisted until 4 hours. We don't have intermediate time points, but by 24 hours, the effect is gone. I expect the effect probably to be gone between 6 and 8 hours. So it's a reasonably long effect and is a reasonably effective response. So let's take a look at other cannabinoid things. I call them side effects. These are clear, well-known effects of the activation of the cannabinoid receptor. And one of them, there is CB1 is present in the hypothalamus. It controls body temperature. Activation of CB1 has been used, which causes decrease in body temperature, quite substantial decrease, several degrees Celsius. This has been often used as a way of testing the cannabinoid receptor activity in something called the tetrad test. But you can see here that in animals treated with HBSS animals treated with THC, which would be these guys here, these green guys here, there is a trend toward a decreased body temperature. But if we look at the area under the curve, so each individual point is not statistically significant, but if we look at the area under the curve, essentially this space here, there is a significant decrease in body temperature. So the THC that we're giving is effective. The animals are responding to it. But one thing that we certainly worry about more than body temperature is the ability of the animals to move in a coordinated manner. And motor coordination is not affected here. You can see this looking at area under the curve, between HBAA and HBSS, there is no effect. There is a little bit of a trend, but no significant effect. So at this dose, 3 milligrams, THC that's what it's supposed to be doing, has effects, and also is analgesic. Does it work after repeated administration? That's a subacute protocol, and let me show you what happens in mechanical allodynia. In mechanical allodynia, you can see that for at least 14 days, that's when we stopped the experiment, but for 14 days, the administration of 1 milligram per kilogram of THC basically normalized behavior, and there was no hint of a loss of efficacy. However, when we looked at cold hyperalgesia, now we see something interesting. We see that there is a very nice response at immediately after injection and also until day 3. Day 7, we start seeing especially at 3 milligram per kilogram of THC, we start seeing what looks like tolerance, and eventually tolerance fully develops. And this is interesting because this is basically modality-specific type of tolerance. Not shocking, but certainly interesting. We call the hyperalgesia being more sensitive somehow to this effect. So this basically is a summary of the work that we have done and published in JPET. You're welcome to take a look should you be interested. But we continue to work that, in our proposal, we not only propose to study THC, we also propose to study CBD. We decided to split into two papers, into two stories, and I'm going to share with you unpublished results focused on the synergism between THC and cannabidiol CBD in the same model. I say synergism, of course, a priori, we do not know if it was synergistic, antagonistic, or neutral, but I am anticipating a piece of data that looks like there is a synergism. Is not the most striking synergism I've seen, but is interesting. And let me get to the data. So by now, you know that we measure mechanical allodynia and cold hyperalgesia routinely in these studies. And this is CBD alone now. And there is work already published on CBD, but we were cognizant of the variability issues, across laboratories. And so we decided to make sure that data was robust. And indeed, it was. These are what you see here. These bar graphs are doses of CBD in milligram per kilogram. And this is time, and looking at mechanical allodynia on the top and cold hyperalgesia here on the bottom right. And you see that now you're familiar with this type of graphs. You see that 10 and 30 milligram CBD is producing a robust effect between 2 hours and 4 hours that fades away between 8 hours and 24 hours. But 8 hours, the highest dose, 30 milligram, is still significantly effective. Now, this is interesting. I'm pointing out these doses because CBD is often used. The main clinical application of CBD is certain forms of childhood epilepsy, where it's used in tens of milligrams or hundreds of milligrams per body weight. So these are very low doses compared to those seen used in the clinic for childhood epilepsy. And cold hyperalgesia follows exactly the same, although it looks like it's maybe a little bit less, maybe more short-lived, but it's essentially the same. Excuse me. Let me just show you another set of data showing that this is subacute CBD. I'm sorry, this was acute CBD. Now this is subacute CBD. So now we are giving CBD every day, once a day, and this is at the maximal dose that we selected here, so 30 milligram per kilogram. And we're looking again at two things, mechanical allodynia and cold hyperalgesia. The results are, I have to say, much better with CBD than what they are with THC, and much to my chagrin. I'm not a fan of CBD. Someone knows that about me, but it really does work fairly well. Mechanical allodynia. What you see up here, the empty symbols are animals that were not basically sham animals. And in these guys here, instead, we have a very nice basically normalization of the pain phenotype, both in mechanical and cold, no sign of tolerance. So what happens if we combine THC and CBD? So normally this is actually, and this is what I'm about to show you, it's not what I would normally do. But one of the problems working with these animals is that they are very few. They don't breed very well. They're very sensitive to a variety of things, and they tend to die, poor critters, when we would rather have them live. So we had a limited amount of mice we could work with. So we didn't do the optimal experiment, but we did run an isobolographic analysis. And this is the results of that experiment. Basically, these are different combinations of CBD. They're sub-maximal concentration. You can see here CBD 0.63, 127, 2.5, 5.8. You remember that in the effective concentration was higher than that. And THC at concentrations that are that end up at the EC50. I told you before about 0.45 milligram per kilogram. So this doesn't tell you much, but this should. This is basically an isobologram. And what you see here is the ID50 or ED50 rather for THC, and this is the ED50 for CBD, and this line cuts the where the theoretical combined ED50 should be, and the combined ED50 should be at this point where the two lines interject, the line interjects. But instead, the calculated ED50 is this one, but the empirically obtained ED50 is shown here in gray. So this is, as I said before, is not the greatest synergism I've seen. I've seen synergisms where the distance between the calculated and the real, the empirical, were much larger, but it is nonetheless synergistic. So what is the basis for synergism, this synergism? Synergism could be of various types, pharmacokinetic or pharmacodynamic. Pharmacokinetic is when two drugs, one drug, for example, interferes with the metabolism of another drug, so potentiates the effect of that drug. Pharmacodynamic could be when two receptors, distinct receptors, converge on the same pathway. And in the area of pain, for example, adenosine receptors and opiate receptors are known to converge. Cannabinoid receptors and opiate receptors are known to converge. Those are very well-established forms of synergism. In this case, however, the problem we have is that we don't know what is the CBD receptor. We know what is the THC receptor, which is presumably CB1/CB2, in this case, probably mostly CB1, but we don't know anything of the sort about CBD. But here's what we found. We found a pharmacokinetic component to begin with, and let me show you what this component is. We measured the levels of THC and CBD in circulation, and let me go through these graphs. We basically, and these are, by the way, HBSS mice. So, and the reason why we use HBSS mice is because their pharmacokinetics is different from normal mice, because their kidney is impaired, the liver is impaired, so they have all sort of trouble. So doing pharmacokinetics, you need to do it in the model, in the specific disease model, and that's what we did. So that limits the number of replicates we could do, but these are individual mice, so you can see them here. So basically, what you see is that if you combine CBD at 5.08 milligram per kilogram and THC at 0.45 milligram per kilogram, you see that the levels of CBD and the levels of THC are higher compared to when you don't combine them. These are not combined. So this is CBD alone, this is in circulation, this is THC alone in circulation, and this is CBD combined with THC, and this is THC combined with CBD, all right? So basically, the addition of one cannabinoid slows down, presumably, I'm extrapolating a little bit the data, but it seems like it slows down the degradation, presumably the liver metabolism of THC. I'm not going to show you the metabolites. We have them as well, but unfortunately the data are not very clear. So at the end of the day, we are left with a question mark here. What is it causing this pharmacokinetic synergism? To make things possibly more interesting, possibly more complicated, probably both, we also found a pharmacodynamic component, but this pharmacodynamic component is really intriguing to us for reasons that I will share in a minute. Let me show you what the pharmacodynamic component is. What we found is that co-administering THC and CBD does something to the endogenous levels, and these are circulating levels of the endocannabinoid 2-arachidonoglycerol or 2-AG. And so these are plasma 2-AG levels, and you can see not much happens here. Maybe there is a little bit of decrease when you give THC alone. It is statistically significant, but it could be some variation. But what is really striking is that when you combine now CBD plus THC, you have a pretty significant increase in the levels of circulating 2-AG, and no change in anandamide, PA, or EA. So this is a clear effect on 2-AG. So why am I so excited about this? I'm not that excited, but I'm interested in it. Why am I interested? The reason is the following, is that there is interesting nascent data coming out of Rachida Sinha's lab, where she has found that administering THC and CBD in patients with pain causes also an increase in 2-AG levels. I say she's found, we measured 2-AG levels for her. So when we look at those data, of course, we were blinded and we didn't know. And she got back to us and said, are you sure? Yes, we are sure. What are you seeing? Well, we are seeing that THC and CBD together increase the levels of THC, which is something in humans, which is something that we are seeing here in SCD mice. The interesting twist is that the patients that had levels of 2-AG increased in humans, this is CNAS patients, were also those who experienced analgesia. So it is very, very intriguing. And I have actually one of my senior postdocs in the lab, Rodrigo, working on it and trying to understand. The idea would be that maybe THC and CBD together are able to activate the endocannabinoid system. And if they do that, then their effect is sort of indirect through activation of this signaling complex. Two more sets of data, if you don't mind. This is not quite, doesn't speak too much to the synergism, but to the mechanism through which the synergism may work. And we're looking now at two sets of events in the spinal cord, oxidative stress and inflammation or neuroinflammation. And we're looking specifically at lumbar segments 4, 5, and 6. We collect them and we measure MDA, malonyl. Okay, I'm blanking on what MDA stands for. I know it very well. It's just like my brain today is not working properly. Anyway, MDA is a marker of oxidative stress, malonyl dialdehyde. And you can see here that in SCD mice, there is a substantial increase in oxidative stress that is basically removed by THC alone, CBD alone, and the combination of the two. Unfortunately, here we could not do an isobolographic analysis because of the number of mice, but it looks like in the effects of both the two agents work well alone and continue working together. On inflammation, the situation was a little bit different and quite intriguing, because if we looked at IL-1 beta, interleukin-1 beta transcription and interleukin-10 transcription, we see something different. So interleukin-1 beta, as you all know, is a pro-inflammatory cytokine, and it's upregulated. Its transcription is upregulated in SCD. And CBD reduces it quite effectively, whereas THC does not have any effect on it. And the combination of the two does not exceed the effect of CBD alone. And it wouldn't, because that's a ceiling effect or a floor effect, if you like. So CBD is having an anti-inflammatory effect. And now, if we look at interleukin-10, which is an anti-inflammatory cytokine, what we see is something different. Now, CBD has no effect, but THC increases the level of IL-10, at least at the transcriptional level. And so when we look at both data together, what we obtain is something that could be synergistic, because we are basically have two different receptors that operate in the same direction, right? Because you can reduce inflammation either by reducing pro-inflammatory agents or by increasing anti-inflammatory agents. And we combine THC and CBD together, we obtain both. So this could be a pharmacodynamic explanation pharmacological molecular explanation, if you wish, for the synergism that we are observing. So this work is finished. My postdoc packed his bags, and he's now, driving to Texas for his first faculty job. So congratulations to Alex Mabutan, and thank you to the CMCR. By the way, I forgot one set of data that I was about to forget, but Alex wouldn't let me forget it. So it basically was really interested in understanding if there was something happening at the level of neuronal cell death in the spinal cord. So he looked at apoptosis. Let me just clarify one thing, that neuronal apoptosis in the spinal cord is a side show. It's not in the causal path of inducing chronic pain. We have demonstrated that. We have a paper in Cell Reports published early in 2025, sometime in 2025. Apoptosis is not directly in the path from injury to pain, but is a marker. And what Alex did, working with Olufunke Ajegbe, a very bright new postdoc in the lab. She's also from West Africa, but not from Cameroon. Alex is from Cameroon. She's from Nigeria. Anyway, so working together with Olufunke, Alex could show that you can see here CBD, THC, and the combination of the two substantially reduces apoptosis in the spinal cord. Okay, on that note, I think that I can just show you what I think is our next step. I think at this point, we really need to mess around. We really need to have what Karst showed us we need. We need an appropriately designed and appropriately powered clinical trial in SCD, I believe, because the data, the preclinical data match are quite solid. We need to be optimistic on that, and we do need to conduct such a study. Whether we'll be able or not is a different ballgame. One thing that remains, I think, unclear is what goes by the name of cannabis. Is it going to be the cannabis available to Karst, which seemed to be a magic bullet maybe so far, or is it a different cannabis, a cannabis that we can get in the United States? We don't know that, right? But that's an important question. And last, I'm going to have to throw a little bit of a picture from my own work. I continue to believe that we need to identify clinical pain conditions that are amenable to a cannabinoid, endocannabinoid intervention. I think the approach that we're using so far, the shotgun approach, which is fostered by the industry for obvious marketing reasons, is failed, and it will continue failing, and we're throwing good money at bad money. We need to identify clinical conditions that are amenable, and for that, we do need preclinical experiments. We also could use, N=1 trials. That would be actually really cool to do as well. And with that, I'll stop and take any questions you might have.